This is Dr. Stone-Gale, and this is a mini lecture on corneal abrasion and foreign body, because these are some common things you may also see if you work in an urgent care, if you work in primary care, if you work in a walk-in center, or even in an emergency center. So what actually is a corneal abrasion? Well, it's a scratch or a cut on the surface of the cornea. And the cornea really is the clear part of the front of the eye, on the front of the eye specifically. And it covers the colored part of the eye, which is your iris, and it covers your pupil. So the cornea has many nerve cells, and this is why there's so much pain and discomfort when somebody has a corneal abrasion, because these cells help you to recognize that something foreign is in the eye before it damages the surface of the eye. So unfortunately, you get a very painful experience when you do have a corneal abrasion. Redness usually follows, and you have intense light sensitivity, and that's where the majority of the pain is coming from. It's the sensitivity to the light, and your eye just continues to water and water and water. So it's very uncomfortable. And these are just some photos of different corneal abrasions. You can see the scratches, you can see the nicks when you do the fluorescein staining. So they really show up very, very well when you use the light and the staining. So what diagnostic studies can we do for looking at corneal abrasion? Well, unfortunately, there's not a whole lot of studies that you can do, but the number one thing that you would want to do is to make sure that you assess visual acuity. This is very important, and it really should be normal unless the abrasion does affect the vision, the visual axis. Also, using fluorescein, which is instilled only after you do a fundus and a pen light exam, and this assesses the corneal integrity. And you can use a Woods lamp, and the Woods lamp will actually highlight the fluorescence in the eye, so you'll see some type of fluorescence green when the eye is lit up with the Woods lamp. But unfortunately, there isn't any specific diagnostic tests or lab tests that you can do for this problem. As far as management for this condition, eye patches really do not decrease pain or promote healing. We used to many years ago put eye patches on patients when they had some type of an eye injury, but that's something that we're not doing any longer because there really isn't any evidence that it does make any difference. Using normal saline to irrigate the eye is good, as well as applying antibiotic ointment or drops to prevent any type of secondary bacterial infection. Analgesics for pain are usually needed, especially in someone who's really having a lot of light sensitivity. And then asking the patient when they've had their last tetanus and ensuring that they get tetanus prophylaxis. And then an ocular foreign body is another thing that you have to be concerned about. When you have an ocular foreign body, it can either be in the conjunctival, it could be the corneal, and when it is a corneal foreign body, those are generally fall under the category of a minor ocular trauma. Some particles could be lodged in that corneal epithelium or stroma, particularly when they project toward the eye with considerable force. So you're looking at rust, metal, wind-blown dirt, glass fragments, wood splinters. The foreign object may set off some type of an inflammatory cascade resulting in dilation of those surrounding vessels, and then you can subsequently get edema of the lids, of the conjunctiva, of the cornea, and if it isn't removed, then it can cause infection or tissue necrosis. When you have a conjunctival foreign body, it's usually because something's got trapped under the lid. So you may be out working in the yard, you may have got sand in it, you could have been at the beach, could have got dirt in it when you were sweeping or anything like that. So those things get trapped under the lid. There's usually no trauma that happens with those. And even it could be from contact lenses. So the corneal one is a little more, it's a minor one, but the conjunctival could be considered a minor one also. You see these symptoms of light sensitivity, your eyes are watering, there's a foreign body sensation, there's pain, and it's pretty uncomfortable. When you do the As we're looking at the diagnostic studies for ocular foreign body, the first thing you really want to do is assess visual acuity with the Snellen chart. And this is for patients that are really not having an emergent condition going on. Even in the case of mild trauma, it's important to estimate the degree of visual ability that's present. So if they're not able to read the Snellen chart, then acuity could be grossly evaluated by finger counting. So you could hold up one or more fingers and ask them to report the number of fingers that they see. Also, the slit lamp after you do the Snellen and fluorescein staining could be done, but this should be done as the last part of your exam. Localization of the foreign body is the prime aspect in managing, and the first question that you have to ask is it in the eye or is it in the orbit? So before they did CAT scans, there was a standard X-ray was used, for localization. A plain X-ray is useful in radiopaque foreign bodies only and will not detect any type of radiolucent foreign bodies such as wood or glass. So the standard foreign body X-ray would include Waters, Caldwell, and lateral views. A plain X-ray film may demonstrate that presence, but it may not locate the foreign body. There's also localization using metal locators, either which are placed on the eye with a contact lens or sutured in, and this may also be done, and that's to look to see if there's any type of metal there. A CT scan can provide much more reliable information regarding the size, the shape, the location of the foreign body. MRI generally is not used in metallic foreign body if you suspect that it's metal, but it's more effective in localizing non-metallic. So if you suspect that it's wood, then that would be the best option for you to order on that patient. An ultrasound could be performed carefully in case of an open globe injury. It's useful if you're trying to determine the extent of the intraocular damage, determining the presence of a retinal detachment or a double perforation or something which you would not see on an X-ray. But ultrasound can give an idea about the nature of the foreign body, such as is it round or is it spherical? And it's also needed if you do suspect the angle of the foreign body, if you want to look at the angle. So for differential diagnoses, you're going to think about corneal abrasions, lacerations, ulcerations. Also, do they have any herpes, ulcers, glaucoma, or hyphema? And this is just a picture of an embedded foreign body, and this is a picture of another foreign body. I'm not sure what it is, but where you can see it there very clearly, both of them. So how do we manage this? Well, the biggest objective is to, relieve their pain, make sure that they don't have an infection or get an infection, and prevent, having any type of permanent loss of function, of eye function. So removing the foreign body, putting a patch on it to protect the eye, and antibiotic ointment, so maybe a polytrim or a Tobrex or bacitracin, siloxane, something like that you can use until that epithelial defect heals to prevent infection. Sometimes there's topical medications for pain or for photophobia, and that pressure patch, on there also. So no corticosteroids, especially, because they foster bacteria and fungal growth. So you don't really want to use any type of corticosteroids in the eye. If there's blood in the chamber, you need to refer ASAP. If there's changes in visual acuity and they tell you that they're having difficulty seeing, immediate referral to ophthalmology. For all but simple non-penetrating injuries. So if it's just a simple non-penetrating, then you could probably treat them. But if it's penetrating, it is a medical emergency and they need to be referred. So your best treatment, if you do know that there's something in the eye, would be very, very vigorous irrigation. That's the best treatment. Rust rings are treated like abrasions once that foreign body has been washed away. And you could use, like a cotton swab or a 30 gauge needle with a handle if you need to use it to irrigate. Rust on the surface can be debrided, but scraping you don't want to do. So sometimes you just have to let the ophthalmologist do any type of removal of that foreign body and only do the irrigation. When in doubt with the eye, I always refer out because I feel it's just a safer bet than having any type of damage occur.